presentation. I would like to introduce Dr. Ngoc Tuan Anh for the title Cardiovascular Outcomes of Coronary Artery Bifurcation Disease Patients Underwent Minicrush Technique, please.
Good morning, everybody. I'm Dr. Ngoc Tuan Anh from the Interventional Cardiology Department of Dàng Hospital. Today, I'm going to talk about my study with title Cardiovascular Outcome of Coronary Artery Bifurcation Disease Patient Underwent Minicrush Technique. As you are aware, coronary artery disease is one of the leading causes of death in the world and Vietnam. From 15 to 20% of PCI cases are performed as coronary artery bifurcation. Technically, bifurcation is challenging, which allows success rate and poor miss and long-term outcome. So we are carrying out this study for the purpose of evaluating cardiovascular outcome of coronary artery bifurcation disease patients who underwent minicrush technique. Firstly, this was a descriptive study that included 33 patients with diagnosis of coronary bifurcation disease who underwent PCI using minicrush technique at Interventional Cardiology Department of Dàng Hospital during the period from March to September 2020, satisfying the inclusion criteria. Here you can see our inclusion and exclusion criteria of patients. These patients were evaluated for the angina and heart failure status according to the CCI angina grade and NYHA heart failure classification. After the coronary angiography lesson that certifies the inclusion criteria would be performed the minicrush technique. The first picture shows you how to perform 9 steps of my minicrush technique, and the second one shows the final result of successful technique. After the intervention, we retook the angiography to evaluate the flaw, narrow degree, and possible post-stenting complication. The technical success were defined as performing on step of minicrush technique without complication. In this study, the endpoint was the occurrence of major adverse cardiac event on May and how it improves the symptom of angina and heart failure after 2 months follow-up. Now we come to the next point. In our study, the mean age were 64.6 plus or minus 40.50. Regarding the A group distribution, the A group over 60 accounted for the largest proportion, 65.6%. Men accounted for the majority with the rate of 71.9%. Inferior or galaxy and colors conducted a study on 199 patients who performed the minicrush technique in 2009. The mean age of patients was 62.11.17 plus or minus 9.75 years old. Men also accounted for the majority with the rate of 83.9%. So the age and gender characteristics in our study were quite similar to other study on patients with coronary artery bifurcation disease. Let's turn to the next issue. Coronary artery bifurcation lessons are common in individuals with multiple cardiovascular risk factors. In our study, hypertension, smoking, and dyslipidemia were the 3 most common factors. And as you can see in our study, there were no patients in group of chronic coronary syndrome. The group of patients with non-ST elevation MI occupy a large proportion in the study, accounting for 59.5%. There was 13 patients with ST elevation myocardial infarction, accounting for 40.6%. However, there were no statistically significant difference between them, with P more than 0.05. Now I'm going to take a look at listen characteristics. Technically, with the minicrush technique or the crush technique, the the angle between the distal membrane and the side brain, the higher the probability of rewiring to the side brain. Therefore, minicrush technique is often chosen a Y-shaped corner. In our study, most of the case has Y angle minus or equal 70 degrees, accounting for 87.5%. Besides, most case has median 111 lesion, accounting for 75%. In our study, the majority of intervention site was the location of LED with the first diagonal brain with the rate of 46.9%. Now, I would like to move to the technical success of our study. In terms of technical success criteria, our study has 29%, which completes on step of the minicrush technique without complication and improved flow and stasis of vascular lumen. So the technical success rate was 90.6%. There were 3 patients who could be rewired to the side brain to the side brain stent struck first failed to pass the balloon to perform the final simultaneous kissing balloon dilatation. Risk ratio was similar to the study of Alfredo Galassi et al. In our study, no complications were recorded during the intervention. This graph shows you how the mean stenosis of the vessel lumen improved with statistical significance in both location in main and side brain with P minus P less than 0.05. This is me to the minus point. Is the initial effectiveness of the minicrush technique in coronary artery bifurcation intervention. In our study, patients were examined after 2 months, evaluating the improvement in angina symptom, heart failure symptom, and MAY. So there were no case of MAY occurring during the 2 months after coronary intervention. There were still very few statistical resources in the clinical outcome of the minicrush technique in the world. So in conclusion, to the 2 study of 32 case of PCI with the coronary bifurcation lesson using minicrush technique, we found that technical success rate of 96% without complication. No MAY were recorded during 2 months of follow-up, and symptoms of angina and heart failure improved after 2 months follow-up. Thank you for the attention.
Thank you for your presentation. Congratulations on your result, especially you practice with a very hard techniques. And so now you see the question and some comment from the chairman and teacher.
Yeah, I have a question.
Yeah, Professor Giang, please.
Thank you so much for your presentation. With the young doctor, you can perform the technique like that. It's very interesting. I appreciate your results. Anyway, I have a small question. Among 32 cases of the stenosis of coronary artery like that, in the result, only about 50% of dyslipidemia. I think that it's very abnormal because mainly of cause of the artery stenosis, not only in coronary artery, but generally of artery also. Why the level of the dyslipidemia only half of the number of the patients? The second question is that why you choose 2 months as a limit for assessing the result? Why 2 months, not 1 month or 3 months and the other time, for example? Can you explain to me? Thank you.
Thank you for the question of Professor Giang. About the first question, only 50% of our patients which have the dyslipidemia is about the problem that we the lipids balance for all the patient, but with as we know, more than 90% of the patient with the coronary artery, we just observe 90%, 50%. It's in the fact that we did, but it's the problem that the exam amount of the patient is so small, so we cannot use it for statistical result. And the second one about the 2 months the examination, because we in this study we only use for the initial effectiveness of the technique, and we exam as 2 months as we call about the condition, or we can contest with the patient, and in the consult, in our patient consult, which just can reject them after treatment. Yeah, it's my.
So anyway, thank you so much. If possible, you can continue to evaluating for the long-term complication. Okay.
That's the proper. We have the plan to the exam, re-exam as 6 months and as 1 year too. And after that, we will do another result for evaluate the effectiveness of the minicrush technique after that. Thank you for
my two ID. That is one ID only, because you see for a long time for the long-term complication related with the risk factor. Among the risk factors of the coronary stenosis like that is dyslipidemia. So we don't let the patient without the following for a long time, so they can let's set some the false results. Okay.
Okay. Thank you.
Thank you.
Yeah.
So just one question: can you distinguish the minicrush and decay crush?
Yeah. Okay. Thank you for the question. And in the about the technique, the 2 standard category for the coronary bifurcation disease, there are many, but such as the crush, the decay crush, and the minicrush, and many one more. But the decay crush and the minicrush, we have difference between the firstly the decay crush. We will do the double kissing balloon, final double kissing balloon after the employment of the membrane stent. And when we rewind to the side brain in the minicrush technique, we use the proximal stent stroke to the side brain, and the decay crush we use the little stent shot. And in the minicrush, we left about 8 to 10 millimeter of the main stent of the main brain stent to do the POT after the employment of the second stent. And about the minicrush, we will do the balloons, the NC balloon dilatation after the employment of the stent in the membrane, with not parallel to the balloon in the side brain to do the simultaneous kissing balloon dilatation.
So decay crush is better than minicrush, or minicrush better?
Okay, in the problem that in that period of the study, we are due to do the minicrush technique, but now to evaluate the coronary bifurcation stenting, we realize that the decay crush is more comfortable and more safe for the patient. So now, right now, at this moment, we do decay crush technique more than the minicrush technique.
Yes, nowadays we use the minicrush more than the decay crush more than minicrush.
Yeah,
because safety and effectiveness. Thank you.
Thank you.